newborn health needs of pregnant and parenting adolescents, including the vulnerabilities and barriers that they face, and how these lead to poorer maternal and newborn health outcomes. Today, our distinguished groups of panelists will discuss interventions that respond to the maternal and newborn health needs of pregnant and parenting adolescents, and will highlight some of the gaps, some of the recommendations, including opportunities to strengthen adolescent, maternal, and newborn health in clinical areas for improved outcomes. So as we wait for others to join in, I'd now like to welcome you to watch a short video highlighting the experience of an adolescent parent in Kenya, describing the experiences she went through as she was receiving maternity care. I hope this will be a good starting point for reflections and discussions on the needs of pregnant and parenting adolescents. So we'll now begin the video before we move on to the presentation. Thank you.
They were children when they had babies. But a mother is a mother, regardless of how young she is. A new study shows that 1 in every 3 teenage mothers in Korogosho has faced a form of mistreatment, one that dissuades them from seeking skilled maternal services. Michelle, not her real name, is one of the girls.
2014 nilikuwa 14 years. Hapo ndo nilipata ball ya first born wangu. Ndo nipate mimba. Sikuwa na pesa ya pada. So kulikuwa na jirani yetu hapo. Mimi nilishinda ndato wapi do kabisa, nilikosa kabisa. Nikamwambia nipe kibarua nimfulie, anipe pesa ndio niweze hata kubai pada. Juu nilikuwa neka hadi cushion. Nilikuwa inani affect napata itch. So akaniambia yeye ana kibarua, the only way anaweza nisaidia ni through alale na mimi. Mimi nikaona just endelea kuteseka. Mimi nika give in na mimi hata sikujua, nilijuanga niko na ball ikiwa 6 months.
Her sister took her to hospital and informed her about the clinics. When delivery time came, she didn't even know she was in labor.
Hiyo siku niliendanga saa 3 ya asubuhi. Nilikuwa naanza kuhudumiwa saa 3 usiku. Ndio nilikuwa naanza kuhudumiwa. Wakanipima. Hata wakuniambia mtoto wako sentimita ngapi, amefika wapi. Akaniambia nimebakisha mwezi mmoja ndio nizae. Hiyo siku ikaisha, ilikuwa Thursday. Friday ikaisha. Sasa Sunday asubuhi ndo nilishinda ngo kuvumilia. Juu nilikuwa dina crawl. Nika crawl. Nikajaribu kushika daktari hivi. Akanichapa hivi mkono, akaniambia nimuache kwa mashughuli. Mimi nikajiingiza, nikaenda, nikapanda hadi kwa kitanda. Juu mtu akishika ngona labor, kuna venye anasikia kwenda choo kubwa. Kwa bahati mbaya nikajienda hapo kwa kitanda. Juu nilikuwa na try kupush na kuna mwenye ananisaidia.
In that frail state, she was forced to clean her mess fast, and for 3 days, she writhed in pain waiting for help, but none came.
Akaniambia sana nipande. Kupanda mimi sijui kitu yoyote. Alianza kunichapa huku kwa thighs. Kiniambia niache ujinga.
Eventually, her baby came out pale and green due to extended labor. Her baby survived and she went on family planning.
Nilifika class 8.
But 3 years later, she fell pregnant again while working as a commercial sex worker, and her trip to the labor ward wasn't.
Thank you. Welcome again. And I hope that the video has given us some food for thought as we delve into the discussions on maternal and newborn health needs of pregnant and parenting adolescents. I'd now like to invite to turn their camera on as I introduce them. So today we'll have 3 presentations. a global health fellow who is working with the Center for Children's Institute at the University of Melbourne in Australia. Our second panelist is Ms. Suchitra, program lead at an organization in India that fetal and maternal rates. And finally, we have Professor Anne Beatrice Kihara from Kenya, who is the president for the all three various aspects of the important group of newborns. Before I hand over to our first speaker, I'd like to invite everyone to introduce themselves in the chat and to post any questions in the we'll pose these questions to the speaker as we move along. So for now, please allow me to hand over to Ms. Victoria Luesha, who's the Senior Advisor for Adolescent Family Planning and Maternal and Newborn Health at Save the Children. She will share the main takeaways from our first webinar. Over to you, Victoria.
Thank you so much, Caroline, and welcome everyone. It seems the network is jumpy, so I just want people to connect the name and the face. So I'll be off camera. Apologies. Next slide, please. So I'm going to take you through the key takeaways from the first webinar that we had on 8th May, which was last month. So from that webinar, we had a number of presentations that covered a number of issues that pregnant parenting adolescents face. We also centered a lot on the evidence, which demonstrates that compared to older women, the pregnant parenting adolescents have lower coverage of MNH services, and they also receive lower quality of the services across the continuum of care. Their newborns and the pregnant parenting adolescents also face a higher risk of morbidity and mortality. And we also had a lot of discussion and sharing around the vulnerabilities that these adolescents face. They experience biological vulnerabilities which relate to physiological immaturity. They also experience developmental vulnerabilities which relate to socioeconomic, cognitive, and identity changes as they transition from childhood to adulthood. And we also covered issues around social vulnerabilities among these pregnant parenting adolescents, which relate to age, life stage, and gender. And these vulnerabilities influence how these pregnant parenting adolescents perceive, seek, use, and experience MNH services. Next slide. What also came out very clearly and strongly from the presentations during the first webinar was that studies on pregnant and parenting adolescents are limited in scope and geographic coverage. And we'll also hear more about this when my colleagues will be presenting, especially Fanazi. And then she's also going to touch a lot on the fact that there are few rigorously tested interventions that exist to improve the health and well-being of adolescents. And we all were very clear from the last webinar that efforts to prevent adolescent pregnancy are urgently needed, and we need a lot of work on that area. But at the same time, we need to be strengthening our focus as well on the needs of these pregnant and parenting adolescents. We've worked a lot on preventing pregnancy, but we still experience these adolescents getting pregnant. So we still need to support them. And these interventions for pregnant parenting adolescents should target all levels of the socio-ecological model so that we are able to document and generate evidence on the maximum impact for these interventions. If we are implementing facility-level interventions, let us aim to strengthen the responsiveness of the existing health systems rather than creating parallel platforms that may not be sustainable. Thank you so much. These are the key takeaways from the first webinar that we had on 8th May. I now hand it over back to Caroline. Thank you.
Thank you so much, Victoria, for summarizing the main takeaways. So I hope those of you who weren't able to join us in the first webinar have a sense of the discussions that we had then. I would now like to hand over to Dr. Farnaz Zabet, who will share key findings from a systematic review of interventions that address the maternal newborn health needs of pregnant and parenting adolescents in low and middle-income countries. Again, Dr. Sabet is a Global Health Fellow at the Center for Adolescent Health at the Murdoch Research Children's Institute at the University of Melbourne. Over to you, Dr. Farnaz.
Thank you so much, Caroline. Look, it's a real privilege to be with all of you here today. Before I launch into the findings of this review, I just want to acknowledge the many voices of the pregnant girls and adolescent mothers that we interviewed that really helped form some of the insights that helped us frame this work. So I'd really like to thank them. And there's a picture of some of them there today. Next slide, please. So what I'm looking at today in this presentation is the purple and orange sections of this conceptual framework of adolescent maternal care, how to optimize antenatal, delivery and postnatal care, and how to improve maternal and neonatal outcomes for adolescents. So we're looking at the health service and community responses. We have a lot of work in the blue area. There needs to be more, there's no doubt, but we already know a lot in that space. We know very little in the green area also, but today our focus is in optimizing maternal health care for adolescents. Next slide, please. So I just want to put a caveat because, as Caroline said, this was a review looking at low and middle income countries. And we all know that low and middle income countries are incredibly diverse. And on top of that, adolescent pregnancy itself is a very diverse experience. It can be completely normal in some settings and stigmatized in others, wanted or unwanted, and for some girls empowering, and for many it isn't. But one thing I wanted to highlight is in low middle income countries, you have unique and different vulnerabilities to high income countries. They include nutrition, infectious disease risks like malaria, HIV, TB, gender norms, and conflict, which is more prevalent in low middle income countries. And for that reason, we decided to really hone in on what we're doing in that setting. And of course, as you all know, 95% of all adolescent births are in low middle income countries. Next slide, please. So this is the review we did. It was published in The Lancet in October last year. I want to acknowledge the co-authors on the review. In particular, Professor George Patton, who was a stalwart advocate for adolescent health for decades, and he sadly passed away before this paper was published. It was an extensive systematic review with no language restriction. We looked at over 50,000 articles and we found an enormous neglect of adolescent pregnancy care. This is despite an estimated, probably more, 21 million adolescent pregnancies annually, and 12 million of them go on to give birth. And we already know we have lots of evidence showing their poorer maternal and neonatal outcomes. I'd also like to highlight that these girls are often very marginalized. They face compound discrimination across age, gender, race. They're often from ethnic or racial groups that are even further discriminated in the communities they live in, and of course, social class. We not only looked at the evidence, but we also mapped the evidence on what a devised framework of what we should be giving pregnant adolescents in high quality care. Next slide, please. So it was a mixed method systematic review, and frankly, it was like looking for a needle in a haystack. There is so little out there that I looked at appendices, supplementary files, anything that shows some evidence of how to support these girls through their pregnancy. Multiple experts, databases, and over a 20-year period. Next slide. So this is a PRISMA flowchart. For those of you that are familiar with systematic reviews, you would have seen many of these. We identified 62 studies, which sounds a lot, but because we didn't look at quality of evidence, we included everything. And most of these studies were at high risk of bias, which means that you can't really infer much from the studies. We included them to show everything that we had. And I want to bring your attention to something here, because as part of the review, we not only looked at adolescent-specific interventions, but general maternal health care interventions and whether they also worked for adolescents. We had to extract about 1,500 full text articles and looked in their analysis to see if they actually analyzed for outcomes in adolescents. From those articles, there was 810 interventions in maternal health that either excluded adolescents, so recruited 18 and above, which is quite standard, or had no age categories at all reported in their findings. So we have a lot of data out there, but we're not looking at it for effect in adolescents. Next slide, please. So this is a geographical map showing the findings, where they came from. It's a smattering. You have one from here, one from there. Again, I emphasize this is over 20 years. The largest proportion of studies were from Latin America, but most of them were qualitative, so we don't know their impact on outcomes. We looked at adolescent-only interventions, which are the blue spots, and the red spots are sub-analysis of adolescents in general maternal health care interventions. I want to bring your attention to India, because the next speaker will be speaking about India. For many years, India has had the highest number of absolute adolescent births globally, and yet in 20 years, we had one specific adolescent maternal health intervention that we were able to identify despite extensive searching. So this really indicates to you the dearth of evidence we have for supporting these girls. Next slide, please. But it's not all doom and gloom. We did find some promising interventions and some places where we need more attention and more research. So Bangladesh was a nutritional study. I'm going to go into more detail in that in the following slides, but it's there as a summary. In Brazil, like I said, there was many qualitative studies, and they really had wonderful insights into care that we provide for adolescents. So although there was a teenage pregnancy unit, the girls really didn't enjoy being in a clinical space. The clinicians were authoritarian towards them. They dismissed their concerns. They much preferred a group session where they could exchange their experiences with other pregnant adolescents and develop autonomy. There was another study from Brazil that was a nurse home visiting program, which first-time adolescent mothers were followed up until their child was 2 years of age. And again, they felt much more secure and comfortable in their own setting. And the nurses also had time to overcome their prejudices towards pregnant adolescents. In India, there was a conditional cash transfer program, JSY, for anyone from India. This is a universal government program in India that's to incentivize institutional delivery. And adolescents uptook that program better than adults. So actually, they are more amenable to behavior change than many adults we see. And Uganda had a really interesting program also, which was a multi-pronged program looking at addressing some of the stigma around teenage motherhood. They had a public goat giving ceremony to break some of that stigma, and the girls were given a goat to assist with their livelihood. And their parents had counseling, and some of the girls relayed that before this intervention, their marriage prospects were very low. They had become pregnant outside of marriage, and therefore this impacted who they could potentially marry. And as a result of this intervention, their marriage prospects went up. So this has long-term ramifications on that girl's life. Next slide, please. So you can go to the paper. We've ensured that the paper is free to access. You do have to register, though, to access it, but all the interventions are summarized in there. And also in the supplementary file, we've summarized all the high risk of bias interventions also in order to help anyone working in this space to get as much information as possible from the article. Next slide, please. So I want to go to show you just how limited the data was. So this was a nutritional study from Bangladesh. It gave lipid nutritional supplementation antenatally compared to standard iron folic acid. And there was one table in the whole article. I was skimming through the papers. Do you have anything on adolescents? And there was one table which showed a fascinating finding that adolescents, if you give them the supplementation, have decreased stunting of their newborn at birth. And it was the only age group where there was a significant effect. Now, not only is this an important finding, but in this particular study in Bangladesh, 39% of the trial participants were adolescents, were under the age 20. So it begs the question that you really do need to look at the trial outcomes in adolescents when so many of the pregnant participants were adolescents. Now, I'm highlighting this article not as a negative thing, but as a very positive thing, because they went on and looked more closely at some of these findings. Next slide, please. So the authors did go and look at this finding in adolescents, and they found really interesting findings. They found that if you give adolescents this supplementation, you reduce newborn stunting by 25%, small head size by 28%, and for insecure adolescents living in food insecure households, reduce low birth weight and reduce preterm birth. These are very significant findings that have huge public health implications. So one of the points from our article was it's important to analyze for outcomes in pregnant adolescents. Next slide, please. So of course, we looked at the data, but we want to know, well, in 2024, what should we be providing for pregnant adolescents as high quality care? And this is really a standard. It's not something we aspire to, it's something we should be doing. So we looked at the STG framework for high quality care done by Margaret Crook. It was good, but insufficient because it didn't quite capture maternity care. So we added the WHO framework for quality maternity care onto that. And as importantly, we looked at the known barriers and challenges that pregnant adolescents face in pregnancy care. This includes stigma, engaging their mother or mother-in-law or partner, etc. And next page, please. We put these all together to create a framework for high-quality healthcare for pregnant adolescents. If you look at this framework, the green is the adolescent-specific adaptation we've done based on a review of over 100 articles. The green is the maternal healthcare intervention, and the black is the original framework. And why this is important, because you can get stuck when you look at pregnant adolescents to look at one aspect of the framework. For example, respect and privacy. It's critical, but it's also critical that they don't die. Their neonates are dying at a higher rate, and there's also higher maternal mortality in adolescents compared to the age 20 to 29. So this whole framework, whole system approach can enable us to think of providing holistic care to adolescents across every aspect of the health system. Next page. Next slide, sorry. So we've done that here. What did we find? We mapped it across the healthcare, high quality healthcare for pregnant adolescents, and you can see enormous gaps here. Delivery. We know very little about maximizing delivery for adolescents in any aspect, whether it's skilled staff, whether it's appropriate testing and referral, etc. Privacy. If you look across privacy, there's nothing that we found that enhances privacy for adolescents in maternal care. Addressing social stigma, like I relayed before, one study from all LMIC over 20 years that's looking at that aspect. Next slide, please. As important as all those are, we fundamentally need to know, are we improving outcomes for them? So if you look here, maternal mortality, nothing. We don't even know how to really highlight decreasing maternal mortality in adolescents. Neonatal mortality is another key area. But then if we look at well-being, infectious disease care, it's worse in pregnant adolescents in terms of the outcomes for malaria, HIV. We have very few interventions that address that. Mental health, only 2 high-risk studies. Nothing for substance abuse, nothing for violence. And then it's, of course, important to look at the neonate. Are we having neonatal care programs for adolescents? It's critical. They're young. They need support. And again, that was very limited. Next slide, please. So we have huge gaps. We've identified some of those gaps in that paper, but there's also an opportunity. We have the opportunity now to really recognize pregnant adolescents as adolescents. As an adolescent health researcher, and my own background is actually in general practice, family medicine, I was astounded to see maternal health care literature referring to them as young adults or young women and not as pregnant adolescents. So we have the opportunity now to shift that conversation and look at providing respectful maternity care that draws on adolescent health and maternal health to move forward. Next slide, please. So there's 2 key policy recommendations in that paper. One is to really have adolescent-focused maternal care in certain settings. So there are certain risks that adolescents have, and they need specific implementation. That's on nutrition. Nutrition is not the same. From all the studies I found, they don't respond in the same way physiologically to pregnant adults. So we need more research in that space. We need more group care interventions, home visit interventions, and we also need to look at how to provide care for a pregnant adolescent that's cognizant of her own development, her baby's development, and often, as is the case in many settings, the significant other, either it's her mother-in-law, if it's early marriage, her mother, or her partner. And in an adolescent, that clinical care model needs to be explored. Next slide. The other key policy recommendation was having adolescent inclusive maternal health. As Victoria said, we don't want a different healthcare system for adolescents. They're going to be in general maternal healthcare, but please identify them as adolescents. They're not young women. Studies should use standard age reporting categories that WHO has put forward and use appropriate terminology. When you have, say, more than 20% of your population in your trial, adolescents, please look at outcomes in them, like that Bangladesh trial did, which was highly important. We need to look at specific adolescent maternal health indicators related to growth and maturation. And we also need to look at adolescents in a positive way. They are sources of innovation, like the conditional cash transfer program. Studies showed that they uptake new behaviors much quicker than adults. Next slide, please. So we were very pleased, of course, that a mainstream journal like The Lancet gave attention to this very neglected issue. And I just want to finish by reading the front cover, because they chose to put this on the front cover of that edition. The policy emphasis has overwhelmingly focused on the importance of reducing adolescent pregnancy. The opportunity to concurrently ensure provision of high quality care to pregnant adolescents and mothers has been neglected. Thank you, and back to you, Caroline.
Thank you so much, Dr. Farnaz, for that presentation. I think it really brings to light the importance of drawing attention to this group of adolescents who are neglected in the literature. Perhaps I could just ask you one question. It's noteworthy how little there is on interventions to support this group of adolescents. Why do you think their needs have been so neglected from programming and research?
Yeah, thank you very much, Caroline, for that really important, but actually quite complicated question. It baffled my mind, actually. And actually, when most people read this study, they're astounded to see how little we know. I mean, one aspect is practical. We don't have much funding in this space, and they're an expensive group, actually, to fund. As Sujitra might share from our experience in India, they're hard to identify, hard to recruit, hard to engage, as any marginalized group is. So that's one aspect. The other aspect is ethical barriers. So in India, for example, adolescents are often, pregnant adolescents are married and they're in early marriage, which is illegal in India. So we had a lot of challenges getting ethical approval to even interview these girls. But there's a deeper narrative around adolescent pregnancy I think we need to acknowledge, and it's a very negative narrative. These girls are seen as irresponsible. We look very negatively towards them. As I said, they have compound discrimination around race, age, and gender. And even the global health community, in some way, the narrative in many of the literature I've reviewed is not the same narrative we see as adolescents. As an adolescent health researcher, adolescents are our potential. They're people that can contribute to our communities. I didn't see one study from anywhere in the world that viewed pregnant adolescents in that light. And I think we have to change that narrative. We have to see them as someone of potential and fundamentally start addressing their needs and their ability to be someone in the future. So I think the whole issue is actually a fundamental issue of epistemic injustice that has neglected these girls.
Thank you for that powerful statement. So we need to overcome the injustice. We need to address the ethics around early pregnancy. We need to think about reaching those who are hardest to reach, which includes this group of adolescents. And we need to address stigma towards this group. Thank you so much, Dr. Farnaz, for that. I would now like to hand over to our next speaker, Ms. Suchitra Rath, who, for those who might have missed the introductions, is a program lead at ECJUT. Ms. Suchitra will share the organization's experience running participatory learning and action groups that include pregnant and parenting adolescents. And these are aimed at improving health outcomes for this group of women. So over to you, Ms. Suchitra.
Thank you so much. Hello, everyone. I am Suchitra. As you mentioned, I'm Suchitra from AGED, joining the call from India. So briefly introducing my organization, AGED, which means Togetherness in Multiple Indian Languages. So I just want to check, am I audible? Because my camera is not working. I'm in a low network zone. Hello?
We can hear you, Suchitra.
Okay, yeah, thanks. Thank you so much. And AGED has been working with marginalized and tribal communities living in some of the most underserved regions in India on the themes of survive, which means ensuring newborn survival, thrive, creating an enabling environment for children to grow and develop and transform, which means expanding the enabling environment in transforming for a better future, especially focusing on adolescents, gender-based violence, and mental health issues through engagement with the communities and building evidence for advocacy. Next, please. Yeah, next, please. So in my next slide, I will be discussing about the participatory learning and action approach, which is an evidence-based participatory intervention that work towards empowerment of rural communities through facilitated, structured participatory learning and action meetings for addressing various issues. Next, please. So what is PLA? So it is a model, PLA or Participatory Learning and Action. It is a model where local facilitators recruited from the community work with the community groups at the village level to collectively explore the consequences of their behavior. And while doing that, they become engaged in decision making and proactively participate in problem solving or addressing their issues. So as you can see, this participatory and empowering strategy is circular, where village women become planners and implementers. They identify problems, find feasible solutions, implement strategies, and evaluate together. The PLA cycle follows a four-phase approach, and that is the hallmark of the community mobilization intervention. And each phase has certain number of meetings, and the number of meetings vary as per the project duration or the themes, and it may be conducted either fortnightly or monthly, preferably in local dialects. Next, please. So, coming to the evidence of the PLA intervention, the evidence from multiple studies suggested that participatory learning and action can lead to significant reductions in neonatal mortality rates with particular benefits for marginalized groups. What does neonatal mortality or NMR refers to? So in public health, NMR refers to the number of deaths of infants within the first 28 days of life per 1,000 live births in a given year or period. And it is a crucial indicator of healthcare quality and maternal and child health. However, while these data were published and for advocating and scaling it up, when we went to the health system to buy in this model, there were concerns that the results might be tied to the fact that the IGJU trial and the replication was managed by an NGO. So in response, the Juhar trial, Juhar is the acronym for Jharkhand Orissa Health Action Research. We use the accredited social health activists who are basically the government appointed community workers to lead the PLA intervention. This study also saw a 31% reduction in NMR with a 61% reduction among the most marginalized. And when the National Health Mission scaled this up across all 24 districts of Jharkhand, I will be briefly describing what the demographics of Jharkhand in my next few slides. But in Jharkhand, when we did this study, we found a 24% reduction in newborn deaths and with the most significant decrease among the marginalized groups. So, and if we calculate or a rough estimate that with this expansion, nearly 12,000 newborn deaths could be averted. So this evidence suggests that PLA interventions, when implemented at scale, can be highly effective in reducing neonatal mortality. This approach was also acknowledged or recommended by WHO, and National Health Mission recommended it to be scaled up in 10 different states in India. Next, please. I'll just briefly share about the geographical scale up of this intervention. It has been expanded by many state governments in India, and you can see the red highlights on this map with over 10 million women participating in these initiatives. Next, please. I won't take much time in describing this slide as Farnaz and during the previous webinar also it has been mentioned that how the status of adolescent pregnancy in globally and in India also Farnaz mentioned that it holds the second highest absolute number of adolescent pregnancies worldwide and with many occurring in the context of early marriage. And she also mentioned that once married, adolescent girls are often treated as women by the society and service providers, uh, which, as you all know, it prevents them from accessing support designed for their age groups. And in the key takeaways, while Victoria was sharing, we also discussed that pregnant and parenting adolescents have lower coverage of key maternal neonatal health services and they receive lower quality services across the continuum of care. So as these young mothers face barriers like limited awareness, social stigma, we already discussed this, and the restricted access to healthcare. So pregnant and parenting adolescents and their newborns face a higher risk of morbidity and mortality. Next, please. So to understand the engagement of adolescent mothers and pregnant adolescents with PLA groups, we did a study in Jharkhand. And brief about Jharkhand, it's a rural state in eastern India, has a unique demographic with a quarter of its population belonging to the tribal community. So in rural Jharkhand, the adolescent fertility rate stands at 73 per thousand adolescents, considerably higher than the national average of 43 per thousand adolescents. So this striking difference highlights the greater prevalence of adolescent pregnancies in rural settings and underscores the need for targeted intervention in the states like Jharkhand. Next, please. To study the engagement of adolescent mothers and pregnant adolescents with PLA groups, a research design was developed in close collaboration. The study involved 29 interviews and 9 focus group discussions with a total of 104 unique participants, of which 26 were pregnant adolescents or adolescent mothers. Additionally, we also did 5 PLA groups with approximately 175 participants were recorded. Out of the 26 interviews with adolescent mothers or mothers to be, 12 were individual interviews and 14 were part of FGDs. So these participants were aged between 15 to 19 and married, with the majority having less than 10 years of education. The study also included 23 interviews with health workers across primary, secondary, and tertiary healthcare, comprising 16 ASHAs and 1 ASHA supervisor. So in my next couple of slides, I'll be sharing few of the findings from the study. Next, please. Yeah. So what did we find? The PLA groups, it provided a rare opportunity for pregnant adolescent girls to leave their homes and socialize. However, their participation was often hampered by restrictive gender norms. We already discussed about this, and in India also, in Jharkhand also, we found the same finding. And it was enforced through community gossip, again highlighting during the last webinar. So this negative gossip served as a powerful tool for unsupportive families to exert social pressure, causing further isolation and distress for the girls. The relationship between these restrictive norms and family support was complex. While marital families often impose strict limitations on the girls' movements, the girls still relied on their support. Without it, they would be vulnerable to financial shocks and lack a safety net. So, despite these obstacles, the degree to which pregnant adolescents could participate in and benefit from PLA groups depended significantly on the level of support from their marital families. So, this support or its absence would determine whether the girls could continue their education or be restricted to domestic duties and fieldwork. Next, please. We also, during her presentation, Farnaz really made two valid points, which I completely agree. One was important to analyze pregnant adolescents in the data and to treat them as pregnant adolescents, not as adults. So, we also did a comparative analysis of the findings from these two groups, and you can see that the adolescent mothers, they often find themselves at the lowest of the social hierarchy, receiving no extra support despite their vulnerability and being treated as women. They are typically very shy and unsure of what kind of help to seek. Uh, for instance, a 15-year-old first-time mother admitted, I don't know anything. I don't know what to do and how things are to be done. So, similarly, a 17-year-old mother who had miscarried her first pregnancy revealed that she was afraid to go to the hospital for delivery because I have heard that madam beat you, opting instead for a home birth. And we also saw the similar thing in the video that was shown during the start of this webinar. So how vulnerable they are, and it's high time that we need to have a separate targeted focus on these pregnant adolescents. Maybe have a combined intervention, but with a specific focus on them. So in contrast, when we, to share some of the findings as shared by adult Prami Gravida, she exhibit greater confidence and are able to demand better services. They also appear to have stronger support at home, leading to a more positive healthcare experience. A 24-year-old woman described her hospital delivery as very nice, appreciating the kindness and professionalism of the nurses who assisted her. This stark contrast underscores the additional challenges that adolescent mothers face due to their age, inexperience, and social status. I'd request the group to think about this, how in the same facility, how there are such disparities between the pregnant adolescent and the adult pregnant. Next, please. These are few of the narratives, and the narratives highlight the restricted autonomy and intense social pressures experienced by women, especially pregnant adolescent girls in village setting, as was highlighted during previous webinar. In these communities, decision about personal matters such as where and when to go out, along with family-related choices like childbearing, are typically made by male family members or older female like mothers-in-law. This dynamic not only limits women's freedom but also makes them more prone to isolation and stress. Establishing a safe space would allow these women to share their thoughts, learn from others, and create a support network. It would give them an opportunity to reclaim some control over their lives, serving as a crucial resource in the environments where their independence is otherwise restricted. And we feel PLA can provide this safe space, but with a specific target with the pregnant adolescent women. Next, please. So what are some of the suggestions? So we would like to suggest that adolescent mothers and pregnant adolescents expressed interest in attending participatory learning and action groups, but face significant barriers to participation. A key challenge is gaining family support for their attendance, requiring engagement and support from the family, particularly from elders and decision makers. The ASHA, or the accredited social health activists, who are the frontline government appointed workers, they play a crucial role as a source of support for these adolescents. But their efforts can be hampered by social isolation among newly married girls. So to address these challenges, ASHAs should receive additional training to effectively engage adolescents and their families. This training could cover communication skills, strategies for involving grandmothers and extending family, and topics relevant to adolescent maternal and early parenting needs. Moreover, given the critical role men play in family decision making, it's vital to engage them in maternal and reproductive health education. So, including adolescent men in sexual and reproductive health education can foster greater understanding and support for maternal health initiatives. So, by implementing these suggestions, PLA groups could better serve adolescent mothers and pregnant adolescents, providing them with the knowledge, support, and community engagement they need. Thank you.
Thank you so much, Suchitra, for that presentation. I think it's really insightful to see how young people can be meaningfully engaged and the importance of creating that enabling environment for them to actually participate. So thank you so much. I would now like to reintroduce our third panelist, Professor Anne Beatrice Kihara, who is the president of the International Federation of Gynecology and Obstetrics, or FIGO, who will speak to interventions to respond to the needs and really highlighting the role of FIGO. So over to you, Professor.
Thank you so much, Caroline, and thank you, my previous presenters. You've made my life very easy. So we can move to the next slide, please. I just really want to acknowledge this invite by Save the Children, APHRC, and the other bodies that are involved. I'm really excited that we put adolescent health on the map, an area of keen interest, particularly for myself, which you will see at the very end. I have no conflict of interest. Thank you. Next. Next. Right. Let's focus. What do you see there? On the offshoot, a teenage schoolgirl. But what is the story behind her pregnancy? And I often tell people, you have the liberty to see what's growing, but we don't know the circumstances behind. Was it rape? Did it happen during a war setting? Was it because I lacked my basic needs, including the video we watched at the beginning, where she didn't even have sanitary pads? But there are girls who struggle for food, for water, for even clean energy sources. Was it because her peers had told her engaging in sex is fine? Was it an indigenous knowledge system where harmful cultural practices push her as a young adolescent not only to drop out of school, but end up pregnant with safe motherhood or unsafe motherhood? In point, female genital mutilation. Next, please. Next, this is what worries me most. And I will use Kenya as an example where I belong, with the triple threat. And I want us all as the audience to really get agitated when you imagine the triple threat means what? This adolescent, not only has she got a teenage pregnancy, she may have been violated, gender-based violence from physical to emotional to psychological, but ultimately with rape, and eventually also at risk or develops HIV. In 2021, we started a national campaign for the adolescent, and particularly the pregnant adolescent, because these are the statistics. Every week, 98 girls aged 10 to 19 were infected with HIV. Every week, 42.4% of the gender-based violence cases we witnessed were in the age cohort of 10 to 19. 20.4% of all pregnancies were in the age cohort of 10 to 19. Ladies and gentlemen, we have a lot to do. Next, please. So the adolescent, I decided to start right from the genesis of why does that adolescent get vulnerable? Hormonal changes with puberty. They get into a phase in their lives of experimentation, exploitation. gratification versus disappointment as they're trying to develop their brains. And you can quickly note the conflict of stimulus and protection versus harm. It is also the age cohort we tend to concentrate on new skills development. So for interventions, this really becomes a critical age period. And then the formation of social networks. It's no longer about mom and dad. It's about my peers. It's about associating even with the opposite gender. And what then becomes lifelong? In other words, they are faced with challenges, they must make choices, and whatever choice you make, there is a consequence. And therefore, we need to have meaningful engagement with adolescents and prepare them for healthy sexual lives. Next, please. I've demonstrated this very clearly on a pictograph. On the left, you can see risky behavior, the eating of junk food, imbibing and smoking and other drugs and alcohol abuse, unsafe sex. On the right side, it's also a time for opportunity. How do you get them to have healthy relationships, engage in physical activity, rightful nutritions that are healthy? Education, education as a continuum, as a protective element for the young growing adolescent. Next. So bear that in mind. And then move to malnutrition. And I really want to speak very clearly, even looking at the slides that Suchitra has shared with us. 1 billion adolescent girls and women suffer from undernutrition, principally in South Asia and sub-Saharan Africa. They're known as the epicenters for nutritional crisis. In 2/3 of them, they suffer from underweight, and from 60%, they have anemia. The number of pregnant and breastfeeding adolescents and women suffering from acute malnutrition alone in 2020 accounted for 25%. I have listed for you the nations that are there: Afghanistan, Burkina Faso, Chad, Ethiopia, Kenya, Mali, Niger, Nigeria, Somalia, Southern Sudan, Sudan, and Yemen. Countries in war and conflict having the greatest brunt. There is a reason I'm going through this. Next, please. Undernourishment leads to what? A weakened immunity, poor cognitive development, increased risk of life-threatening complications, particularly in pregnancy and childbirth, and with dangerous and irreversible consequences for children's survival, growth, learning, and even their future earning capital. Next. The opposite is obesity. And we have seen studies done by UNICEF and WHO. In 6% of under 5s, they're overnutrited and obese. In 18%, they are overweight. And this seems to be doubling. In richer countries, they're not exempt. But we are increasingly noting we're having more and more of this happening in poorer nations. Why? We need to begin to look at consumer determinants, the junk foods, better known to all of us, the lack of physical activity and sedentary lifestyles we seem to be adopting and adapting, and the lack of education on food security and healthy, nutritious foods, and including indigenous knowledge systems. Next. Now, as far as nutrition is concerned, if there's anything you need to take home, is to realize two things. I am a young adolescent, I'm undernutrited, or I'm overnourished and I'm obese. Looking at the extreme right of the same slides, undernutrition, overnutrition, that child is already fetal programmed for non-communicable diseases, high blood pressure, cardiovascular disease, fertility-related issues, and including reproductive cancers. So we cannot take nutrition any more lightly than we have been. Next, I've called it the ticking intergenerational time bomb. Now, let's move to the pregnant adolescent. What are the challenges? And noting for these young girls, they're often unplanned, mistimed, or even unwanted. The risk for this group: malnourishment, abortions, preterm labor, pregnancy-related complications, non-communicable diseases, as I've just told you, communicable diseases, obstructed labor with vesicovaginal fistula, PPH, the small vulnerable neonate, if it survives, intrauterine fetal death, maternal and neonatal mortality. Most of these girls will drop out of school, will lack employment, have economic dependency. We've heard about disrespectful care and the healthcare providers being judgmental and biased. Lack of access even to maternity services, lack of partner support and taking on of responsibilities, the triple threat, lack of connectedness, the isolation that Suchitra talked about is because of lack of connectedness and gender disempowerment. Next.
Professor Chiara, just bringing to your attention the time.
Yeah.
Still, yeah.
How many minutes? I'll go flying. Okay.
We're 2 minutes time.
Sorry? No, you have to give me 5. Now, interventions for prevention of pregnancy, you can see counseling, age-appropriate comprehensive sexual education, and a whole host of adolescent youth-friendly services that I have written up for you. We must move upstream. Next. Other interventions, look at the indigenous knowledge system, health equity, community engagement, gender equality and empowerment programs, and really address the normative environment, health promotion and primary prevention strategies. Next. Parenting adolescents, here I only want to bring to light 3 things: the timing of your first adolescent birth, the spacing between them, the quantity of total number of births, and your lifelong reproductive choice. Next. So challenges, again, would be similar, but now you have a baby. So we really need to look at what can you do for this individual. Next, please. Landscape. You must look at interventions that look at transitioning to independence and having adolescent and youth-led social accountability. Next, please. Reproductive and social justice disrupt the increase in their vulnerability. In fact, it is clearly known with the parented adolescent, she will probably have twice the likelihood of getting a repeat pregnancy. And I've enlisted for you those complications. And you must move her from gender disempowerment to gender empowerment. Next, please. Effective communication. If there's any message I want us to all take home, we are not talking with the adolescent. We are not talking to the adolescent. The language of understanding, the role of influencers, channels of communication, we really need to address. Setting of boundaries, positive reinforcement, particularly if you're a parent with a young one. Next. Conflict resolution, emotional support, education and guidance. And here I really want to speak to parental guidance and supervision for this adolescent parent. Next, please. Seeking professional support, cultural sensitivity. Next, please. This is really where the role of the gynecologist comes in. You can either take an adolescent to the trajectory of demographic dividends or a missed demographic dividends. Next, please. I'm almost done. Gaps, and I'll just fly through the gaps. 1, we all must invest in human capital, and particularly the adolescent and youth. So how much more should we be addressing their sexual reproductive health and rights? Next. So the investment case. The second one is the element of boys and men in parenting roles and responsibilities. We need to have a relook at this, holding them accountable. Next. Moving the adolescent to empowerment. I will not belabor to that. That is very important, and particularly gender-related issues. Next. Bridging the gaps, curriculum. I work in the university. We are yet to even start a subspecialization in adolescent and youth health. And I believe this is also attributing to why data is skimpy, even within academia, beyond what Fanaz talked about. The role of gatekeepers, timing of intervention models, multi-sector collaboration, and obviously meal and the ability to conduct research like my colleagues have alluded to. Next, please. Measure, measure, measure. Disaggregate data. The adolescent data must be teased out all the time for impact. Next. Lastly, adolescents have voice and agency, and they must be brought to the table. We can no longer talk about them without them. They must be center stage. Next. So what has FIGO done? We have actually introduced the Adolescent Health Committee. I had the Well Woman Committee. When I took on the presidency, I insisted the adolescent must be dealt with as a separate entity. And I've also introduced the technology group because I believe the adolescent does not read, they use technology. Social media is point in mention. Next. Next. The role of the gynecologist. Sorry, go back, please. One more. Go back. Curriculum, guideline development. Go back. No, go forward. Forward. Curriculum, guideline development, capacity building, patient education, publications. My colleague said she looked for systematic reviews, unavailable. Collaborations, research and multi-sector engagement. The last slide. The greatness of our lives is not what we leave behind, but what we send forward. I was a young mother, 20 years when I did get my pregnancy. Today, I'm at the pinnacle. It is possible to change the adolescent's trajectory. Thank you.
Wow, thank you so much. What a powerful take home. The greatness of our lives and what we can do to move things forward. Thank you so much, Dr. Farnaz, Ms. Suchitra, Professor Kihara, and Ms. Victoria for those interesting presentations and very powerful words for us to take home as we think about how we improve the maternal and newborn health for pregnant and adolescents. We're 5 minutes over, but I still see 90 people still on the webinar. So this is great. It means that this was important and valuable. So I really also want to thank the audience for participating in this webinar and our previous webinar. And I really hope that this conversation shed light on why stakeholders, partners, and donors should be investing in responding to the needs of pregnant and parenting adolescents so that we can see improved outcomes for them and really for all young people and their children. So very, very powerful words. Before people log off, I'd just like to request if everyone could take a moment to access the webinar evaluation link, which is posted in the chat, as well as the links to the resources on the issues that have been discussed today. Since we're out of time, we are not able to go into all the questions, but we are recording them and we'll be responding to them via email as we share the recording for this webinar. But again, thank you, Professor Kihara. Thank you, Farnaz. Thank you, Ms. Suchitra, and thanks, Ms. Victoria. So thank you, everyone, and wishing you all a lovely day or evening, depending on where you are. Thanks.
Thank you.
Thank you.